Yep. Okay. So I'm gonna get out of this Dr. Sarkis Nalbandian.
Yes.
Right. And we both should be there. So leave meeting. And there you go. Wonderful. So that's better. You're the host, I'm the co-host. I can control everything from here.
Excellent, excellent. Thank you, thank you. Zoom, Zoom, share. No. New share. Okay. Well, it's all happening, huh? Hi, Shraddha. How's everyone? Can you all hear me? Waiting room, no. Just wait a little bit. No, Shra, are you there?
Yeah, Dr. Sarkis, I'm here. Just give me a minute. I'll put you on mute. Yeah, we've got 17 people. Let's just wait for another 5 minutes. I think the time zone has changed.
You sure that's fine? So we'll wait a bit longer. No, I'm waiting for Stan to join in. Did you send Stan a link? Let me see if I can send. Did you send the link at all or not really?
Pooja does that, I guess.
Let me just have a look. Let me. I'll just send this stand off. Okay. Just send it. I'll send him a link so hopefully it come up. Admit. So you're admitting all. Pooja, you're admitting all, right? Okay.
Yes, Dr. Sarkis.
Good, good, good. Okay. It's getting up in volume. Okay, text just came. Pooja, it just arrived, so we're gonna wait a little bit longer, guys. Anyone's got any question you want to ask me? Verbally, you're most welcome before the webinar starts. Any questions at all? No questions. Robbie, you must have a question.
Sorry, Sarkis, not on this topic, but perhaps another time.
Poor Robbie. Not this topic. You know, this is probably the most important topic. I can assure you, this is the most important topic that we have a problem with. It's a real problem in terms of what you're thinking. But it's something to talk about. This is a very common problem, and patients only 46 years of age. Yeah, a lot to talk about. I'm just waiting give a bit more. It's just happening. So give another 5 minutes, Pooja and Shraddha, or no? Just waiting. Oh, yeah.
Stan boy.
Stan, I'll send you the link. Okay, what I'll do, I'll send you the link by WhatsApp. Will you pick it up from there, or it should be in your email? Have a look at your email. I just sent you. Yeah, I've sent about. Just check your standby email, yeah, please. Should get it. Should get it. Yes. It should be there. You just click it'll come. Yeah. Okay. Yeah, yeah. No problem, no problem. The participant started, so you might have to go along with it. It's okay. You can have a think. Thank you. Bye. Bye. How are you going so far? You're almost coming to 30. Any questions, anyone? No? Anything that you want to talk about before we start? I'm just waiting for Dr. Biasis to come in. I have to apologize for that. Shouldn't be too long. Any questions about this case or similar case that you might have in your practices? Happy to help you along those lines. So please be my guest and ask any questions you may have, and happy to answer them. Now, I think we're getting there. Stan's joining. Just trying to think. Stan. Not yet. Just wait for Stan to join in. Pooja.
Yes, Dr. Sarkis.
When Stan comes in, just please admit him ASAP. Make sure he gets through.
Yeah, sure, of course.
Looks like nobody wants to ask questions.
Looks like people are still on long weekends.
Still on long weekend mode. I see.
Yeah, long weekend mode maybe.
Fair enough.
And I have a question on what you about the topic you did 2 weeks, two seminars ago.
Right, go ahead.
You remember the, I think it's our cosmetic topic, and remember you talked about one of the lady who's some of the ADA members' family you treated.
Yeah.
So just wonder, when you see cases like that, do you go through a protocol? Initially, I look at the vertical, improve the vertical height of the face, and then the horizontal, improving the horizontal. Do you go through a plan, or you just look at it and?
I'm listening, yeah. Of course, you have to keep those patients that present in your clinic, they're very well informed about dentistry. In other words, they're judging on what you have to say. And so when you look at those patients, you have to understand what's going to be the end to position. In other words, where you're going to end up with. How are you going to look? How is this patient going to look? There's no tools that you can, for instance, so for me, it's very important that I do the diagnostic mock-up graphics should be. There's no sort of, how do you say, recipe in terms of every patient is different. This is why we treat these patients case by case basis. That's the reason it functions, because we're trying to explain the patient. And during the college we teach you is what to look for, what aspects to look for to be able to give something to the patient which you think is right for their face, also the patient feels is right for them. So when they give, for instance, Stan, good evening, how are you? Thanks for coming in. You're coming as a Sarkis value, that's quite okay. It's fine. There's 2 Sarkis values.
Unmuting. Right. You should hear me and you should see me.
That's good. So in other words, when you decide to this complex stuff you work, you must know the end position. If you don't know the end to a position, you don't know where you're going. And that's the key to good aesthetics or any reconstruction. Now, I have a number of cases this week, a big complaint case that's come in where she had all this veneers put in, but she can't speak. Now, when I asked the question, did you have any temporary work? I said, yes. And I said, well, could you speak when you had temporary veneers? No, I couldn't. So what happened then? Well, then I said, when the final one comes in, you'll be fine. Well, it didn't work. So it's been 4 weeks to the final, had to wait another 6 weeks, almost 3 months. She can't speak. The new one, she can't speak. So now there's a disorder. It's called dysarthria. She can't articulate properly. So does it make sense, Ravi, what I'm talking about? Is it Ravi or Jesse? Who's asking the question? I'm sorry.
Ravi.
Ravi.
Me. Yeah.
So you need to test the system. And every case is different. That's what I'm trying to explain. This is why we got college. It takes good 2 years for you to learn to be able to comprehend, articulate, not to have a recipe and everyone will fit the recipe, it won't work. I would say about 30% of patients, the recipe won't fit, and that's where problems occur. With 70% of the patients, you can chuck a brick in their mouth, it'll work. But the 30% usually doesn't work. And that's what I'm talking about. But thank you for the question. Was that answering your question? Sorry, Ravi.
Yes, but I guess when I go through the course, I think I'll get more in-depth understanding.
Let me discuss. So when everyone comes in with their 5 cases, you'll be looking at 100 cases.
Mhm.
So there'll be me on board, there'll be Stan Boyas on board, and they'll be on board, they'll discuss all cases. Like, all the prep, this lectures, webinars I'm giving is all about preparatory phase to see what you're going to do before you decide what to do. The problem is that everyone, I don't know why the general dentists never like periodontics. Is the key to everything. I mean, somehow it's always restorative the base, but periodontics is the key. Without good bone health, without good gum health, everything will fire. Your foundation is periodontics. That's why I consult my periodontists with all the time. And it's important to understand that. I mean, this gets done in my practice with the hygienist, but Stan knows his case, so he's well versed in the case. But this is everyday dentistry. It's an everyday dentistry that we need to do to be able to get the patients on board and help them out to decide. For instance, one of my colleagues told me is signing for the course that he's signing to do all-on-4 course. Now I know that if you look at its case, it's an all-on-4, no question. And a lot of people say, well, it's all-on-4. I can tell you, can lose all those teeth, but we can take all these teeth out, shape the mandible, shape the maxilla, and put some implants. To be honest with you, this is a very difficult all-on-4 or all-on-6 on both upper and lower jaw. It's a very difficult case, and people don't understand that. So to me, I would never start all-on-4. I would never consider any of those cases, and I'll show you why. But we can manage these patients, and we'll discuss how we manage patients. The reason we do this seminar webinars is to be able to make you change your paradigm, make you rethink. And when a patient's coming in, you don't just open your mouth and say implants, or we must say crown. Just sit back and think. And think, because I believe that thinking is a precious commodity. It's a real commodity. So this is one of the reasons this course is about, is to make you think, because we teach. Someone there's a consensus that I want a recipe. I want you to sit next to me and show me how I'm going to hold the handpiece, I'm going to drill a tooth. Hang on a minute. Before you do all that, do you know where you're going? That's the key. So now I have still a lot of problems. It's exactly I know what the dentist is thinking. So I'm here to help you. I'm here to help you to think differently, and that's what's all about. You're going to think different. So we have a patient who presents in our practice. Obviously, you can see there's a considerable bone loss. Her main complaint is that my teeth are moving. And the second complaint is chewing is getting more difficult. Now, typical story, you get this patient probably maybe 2 or 3 times in your surgery. I get the patients in a very similar rate, and I consult with Stan Boyatzis, but there's a lot of things that are quite obvious in this case. And we need to sort of be very mindful of, okay, here we are, how do we go about, looking at this patient in the long run? You see, what I find in many ways is that when patients present in our practice, living long, like this patient's 46 years of age, and she's got a bone loss. So when you think about, now I'm going to think about, putting implants here. Well, she's only about 46. What happens then? What happens when she's 50? What happens when she's 60? What happens when she's 70 and 80? What happens then? You see, it's something we need to think about because, in my opinion, that we need to think about the future and not the present. The present, unfortunately, doesn't mean much in terms of what you're planning is the key, or what the patient is going to achieve for now and for the future. But we can decide to. It's like having your leg has got an infection, and if you don't treat the infection, it's going to become gangrenous, which will have amputated. But if you try to treat the infection, you'll be able to save your leg, and that will prevent prosthesis, or leg prosthesis, or prevent any major other surgeries because you managed to save the leg. And we need to think about the same concept when you approach the teeth. We need to manage to save the teeth, and most importantly, the foundation that supports the dentition. And this is something to think about. So don't be so hasty when you think about just go on. And decide what will be the best for this patient in the outcome. Now, just quickly, I can talk about the college later on. I'll come back to that. And we're getting quite a few signs, and it's all going very good. I'm very, very happy from the response. And also the fact that we have a new course coming up, the online, very soon. And this will be an online course, full day, and in a composite or porcelain veneers, your decision-making process. And I'll go through step-by-step approach. Ravi, you might like this in what makes me decide to do composite, what makes me decide to do porcelain. So, that's a sort of porcelain, that's a composite, and we'll discuss all the different avenues for my decision-making process, why I do the things that I do, and what I think is the best outcome for the patient. So in that way, patients are able to make the right decision. So this will be online soon. We're going to work out a date, but that's coming in, and you're most welcome to come in and go for that course. So here's our patient. Our patient is about 40, 45, 46 years of age, female, and she presents. What do you see? I mean, anyone, please, like to come up with an idea. What do you see with this patient? She complains of mobile teeth moving, and she says chewing has been uncomfortable. What would you do in this film? What do you see? What is your first impression for this patient? Anybody in the audience, please. There's no right or wrong answer. I'm gonna pick a student. Anyone? Ravi, how about you? What do you see?
A lot of things.
Go ahead.
Failing bridge work, maybe in the anterior. A deep bite, possibly.
Okay. What do you see from the picture? Here's a picture. What do you see from here?
decay between 1-1 and 2-1, but probably there's a midline shift there. There's definitely a lot of perio pockets everywhere, especially lower anteriors, probably lower.
All right, let me help you out here. Patient's complaint is that my teeth are moving, and the second complaint is that, I'm just having a problem eating.
I have no idea. Hey?
Yeah, someone's commented. Oh.
Can we mute that, please? So, okay, any other, thanks, Ravi. Any other comments anybody can see? Is,
There's
Go ahead.
a comment from Christina. She says disaster.
okay.
Please elaborate. If
Elaborate, let's go. Dr. Howard? Well, it's
Christina says it's a complex case.
right. What do you see? Like, I want to know, what do you see? I'm sure Stan is exploding at the moment, Stan, but
Yep, that's good. We want two-way conversations.
you know what we want, but I want to get out of you guys. Come on, guys, let's move it.
Okay, this patient comes into your surgery. Where do you start?
I'm going to pick some over here. Isidore, are you there? No, he's not there. Okay. Can someone please elaborate? Anyone? No one?
Dr. Sarkis Paranas says bridge is loose, possibly moving. Some
you-
subgingival carious lesion. Betty says perio. And
Okay.
we've got another comment. Just give me a minute. Shine says perio inflammation, most likely moderate to severe perio.
Okay.
And
That's
we
all.
have another message. 1 second. Queenie says poor plaque management, irregular visit to the dentist.
Yeah, but you don't see a regular visit to that. We don't know what's happened in history. We are only assuming. So I like, you see, you're seeing this case. I mean, I see the most obvious thing here that needs to be said. I want someone to pinpoint to me, what do you see? Don't give me a elaborate, just what you see, what's your first instance? What I see is, what do I see?
Multiple failures of dental treatment in the past.
Okay, I understand that, Christina, I understand that. I want you to tell me what you really see. I mean, Stan, am I right what I'm saying?
Just said, yeah.
Maybe,
As I
okay.
said, this patient is presented to your practice. Where do you start off with?
Refer to you, Stan.
No,
What
seriously.
no, all right, let's go. We're supposed to have it as a two-way conversation,
Sarkis,
right?
Let's talk. Yeah.
We've got a few comments. Jesse says, need an OPG, please.
Yes.
HA says anterior edge to edge bite, bilateral posterior open bite.
Listen, this patient happened to have a picture taken by bringing a protruding jaw into edge to edge. You guys, it astounds me, but I want you, this is the reason I put this picture. I have a reason why I do this, by the way, because I know what people are thinking. You see what I'm saying? I like to know like what people are thinking. And the important part is what you really see here. First instance comes in your practice. What do you see? You say, are you a class 1, D1 or whatever, or D2? Is that what you see? I mean, what do I see? Number, it just sticks out immensely. I want you to start thinking.
Heavily restored dentition.
All right. I'm looking for something more. Stan, am I saying the right thing or not? I mean, but we haven't spoken about this case, right? You're coming in and you're seeing what I'm seeing, right? So I want everyone to think. What would you
Okay,
do?
what's the patient's complaint? Let's start from there. They've come in there obviously with a particular complaint. What's their complaint?
They can't chew and their teeth are moving. What do you see? Nice one, by the way.
Collapsed part.
I'm sorry, I didn't hear that.
Collapsed part and passive OV eruption of the anteriors.
Who was this one? I didn't see.
Nana.
Leonard, correct? Okay.
Obvious period.
So, okay, I think, Stan, what the situation is that dentists are very concerned about the occlusion, Stan. You see the point? I mean, they're very concerned about the occlusion, and they're more concerned how the teeth come together, because it's part of the teaching. It's not their fault, it's part of the teaching. Okay, now when I'm looking at this case, it says I've got drifting, moving teeth, my teeth are mobile, and I can't chew properly. So, and it's painful, right? So what it tells me is that patients' teeth are mobile, that's something with a support. They can't chew really well. That means it's a mobility, there's some pain associated. Now I'm looking at the mouth. I mean, and what would you say? What you see? You just said what you see is that periodontitis. I'll tell you what I see as a prosthodontist. You can add on if you like as a periodontitis. Is that okay?
Yep.
Okay. Well, the first thing comes in my mind, I see gross amount of calculi. Okay, I see loss of attachment. I see hyperemia, huge swelling of the gums. Okay, redness of the, all right. I see the redness concentrated in the lower anterior and upper anterior, so there must be also all around the mouth. I see poor hygiene. I see food stagnation. Okay, at this stage, that's what I'm seeing at the moment. Okay, forget the loss of attachment; it's all there. Multiple gum recessions. I see puffy gums, redness. If I press over here and I press over here, there'll be pus discharge or exudate for the or for the periodontal pockets. So this is a chronic inflammatory state with some acute inflammation anteriorly that's causing the patient pain. I'm not seeing the occlusion. I don't care about the bite. It doesn't even register in my head. Stan, you proceed, please.
Well, it's basically, that's why we said the patient presents, what do you see? Obviously, if you look at the gums, low anteriors, that stands out. You see the caries, right? So the patient can't chew. You relate what you see to the patient's complaint. They can't chew. My teeth are moving, right? And you can tie that up.
It's simple. What do you expect to find? What would you do from here? Please talk. What would you do from here? What's the next thing you would do?
An OPG and a full barrier jaw, I guess.
OPG, good on you. I'll take an OPG quickly because before I sit down, it's just easier to take the patient to the OPG room, take the X-ray. Fair enough. I mean, Stan will do that. Stan will do something else before then. I know what you do, Stan. That's coming up. For you, it's coming up, Stan, just specifically for you, okay? So he will do something else before he takes the X-ray because there's something that Stan would do, and I agree. That's what I would do in my room, but OPG will give me an idea. Usually people come with their own OPG, so immediately OPG is there, I can see what's happening. But let me ask you another question. This gum is really, really puffy, and I see plaque calculus. Can you see the calculus here? Calculi? Can you see it? That's not decay, actually. It's actually calculi. Okay, can you see all that? Can you see it? Yes or no?
Yes.
Yes. Please say yes loud, because it's easy if you say yes, then I can get on to the next one. Then I can finish the webinar. But I'm really trying to make an example. Yes, thank you.
Dr. Sarkis Farana says supragingival debridement under LA next.
Yeah. Okay. Very good. Now, when I get supragingival calculi here, Stan, I just want your consent before I proceed. And I'm looking at all this redness here. Does it tell me that this is like the tip of the iceberg?
Yes, there'll be deposits guaranteed down there with that swelling on that. So if you're related to your OPG, have you got the X-ray? Can you show both clinical and OPG together?
I will do that in a minute. I will do that in a minute because I've got something else before that, but I'll come to the X-ray in a minute. But here's another question. Okay. If there was no calculi, there was a clean mouth, Okay, what would you think if you had all these problems? What would you do? What was the next thing you would ask the patient? But when you put the patient on the dental chair, what would you ask the patient?
Medical history, I guess, systemic factors, medication.
Very good. What medication would be doing something like this?
If it's hyperplasia, it could be a calcium channel blocker, right? If it's hyperplasia.
Such as? Give me an example. Any, don't have this brand name, like for what?
Dr. Sarkis, we've got a few comments. Queenie says autoimmune condition. Farana says diabetes.
Okay, what else? If it's medical related, I understand if it's medical related, drug related. But what drugs would cause this?
Anti-epileptics.
Okay, could be. Okay. Dan, what do you think? Will it cause epileptics, this problem?
I think, you've got to relate, all right, you see this, you've got to go through a full medical history, right?
Yes.
With that, you can then assess, is it diabetes? Are they diabetic? Controlled, uncontrolled? You're looking at something more than just the calculus there.
Exactly.
Right? Obviously, there's going to be subdeposit. You want to eliminate any systemic influence on that there, right?
I will take a full history.
Yes.
Full history. I don't even want to know in the mouth what's happening. Usually I take my photos. I want to have full history. I'll ask the question, where was the last checkup? What did you do? What's your medications? What have you had? Full history. She's about 46. That's the problem here. So let me give you a scenario. Okay, calcium channel blocker, like high blood pressure tablet, nifedipine type. Okay, so what happens is that they can cause this. So the good thing is she's not taking any medication. So what I think, and I think Stan would agree with me, when I see calculi and I see the redness, I'm really happy. Am I right, Stan? Because
Yes.
you explain 1 and 1. I'm happy. See, let's say they came to you, and this patient came to me, has been to 3 dentists, and all want to do all on 4 or all on 6. I mean, what would this mean if she has got history at the age of 45 or 46 of advanced periodontal disease? Okay, what happens when you do all on 4 or 6? What happens? Does you just eradicate disease? You think those bacteria just disappear because there's no periodontal tissues? You don't think they're going to come back? Of course they're going to come back. You think there's a high risk for gum loss and bone loss? What, implants going to stabilize the bone? I'm still getting patients who come in and dentists keep saying to me, oh, my dentist said if you put an implant, it'll stop the bone from losing. That's crazy. Bone doesn't give a stuff about the implant. Get it through your head. Bone doesn't give a stuff where you put implants or not. When you lose that tooth, bone goes where it wants to go. It's genetically determined, not by dentists or implant type determined. Would you agree on that, Stan?
Yeah. Yeah.
Good. So what Stan would do, he would say, I want to see periodontal charting. Is that correct, Stan?
Yeah.
So
medical history, what have you determined from the medical history?
She's basically has a bit because of fear, anxiety, it's just a neglect.
No medications?
No medication.
Okay.
So you can see the severity of the bone level, attachment loss, the bleeding or probing, most of the teeth, especially lower anteriors. So we have a considerable bone loss. And what we find is that for a lot of these patients, they are severe with severe anxiety. They simply want, they want a solution. They want someone. Yes, I'm listening.
Yes, Dr. Sarkis, we've got 2 questions. One is from Queenie. She says, does the patient smoke? And Farana says, is he or she a mouth breather?
Okay, none of them, because she doesn't smoke. It was obvious she doesn't smoke at all. And I'm not sure if she's a mouth breather or not. If she was a mouth breather, what would you find? Where would you find inflammation if she was a mouth breather? Where do you find the redness? Upper or the lower?
Upper.
Upper. Is it, where are you finding here? Where's more redness, upper or lower?
Lower.
Thank you. Good answer, good question, but it's there. So the idea is to be able to, understand. It's a simple picture, and yet it's diagnostic. So when you guys do your case assessments and you're doing all the your case presentation, you will know how to think. In other words, you will know exactly what's the best way to help your patients, and that's what I want you to think. So coming back to period chart, okay, we have quite a look at the loss of attachment here. Like, I mean, well, we're going to lose our tooth, the upper right 8. It's well, I think it's probably 8, but that should be an 8, I believe, or 7 here. But I think it's a chart is 8. But overall, we have quite a bit of bone loss. 7, 6, 7. So it's a 6, 7, 9. Canine 9, 9, 9. I mean, we have a lot of bone loss, and we have a problem here. They're all bleeding. Look at mobility: 4, 3, 3, 3, 1, 1, 1, 1, 1. Coming in lower. Look at the lower: 4, 2. I mean, when I look at the mobility here, just looking at the mobility here, I mean, she's got pain in lower anterior. Well, you expect mobility to reflect that, don't you? You see, what I'm thinking is that when you start doing your numbers, okay, it's very important to understand that doing the numbers is essential, because it allows you to think in terms of you've got some sort of data to collect, and then you've got data to collect and relate to the patient's symptoms, and also relate to your radiographic analysis. Is that correct, Stan? Well, can you comment on this, please?
Well, obviously, you're looking at loss of attachment, and loss of attachment is a combination of recession and probing depths, right? So you can see all those starting from the upper right-hand side. You've got probing depths of 9s all the way through. So 9, 6, and 7. So overall, what, based on this information and also on the radiographic information, Sarkis, can you just pop an OPG or some form of radiograph?
I'll do that in a minute. But the reason why I'm talking about getting data is because when you can, to manage a disease, you must measure it. Okay? Because you can't manage it, you can't see your progress unless you measure it. If you measure it, you can manage it. But you have to have a base data to start from. So whenever colleagues tell me, oh, look, I've got this problem, can you help me out? Yes. Can you show me your base data? I haven't got any, but I started treatment. So you can't start treatment until you've got base data, so we can have a look. Even if you do a normal for you, I've seen the period chart. You don't want to know if you could save those teeth. But if things go wrong, if the patient comes back, we know that we could save those teeth, then we have a problem because we could have saved those teeth. And our option was. So here's what you'll be waiting for. Now you can see here, this is in the air. This does look like on the air on the left 7, left 6, but it's not. So your overall bone loss, you can see the bone level here. It's OPG, it's not quite accurate, I accept that. But for all intents and purposes, okay, you can see that's gonna go, we lost that one. But do you see that something really obvious that sticks out that really makes me feel happy? Can someone tell me, please?
Calculus.
Calculus, thank you. It sticks out like a dog's balls there. Okay, and that makes me really, really happy. I also see a infra-bony pocket formation. Okay, Stan, is there anything else you'd like to comment? I don't want to say all things.
I would have liked to see something clearer around the low anteriors, because you'll find that there'll be calculus on the lingual of those, almost splinting them together.
And I had the CT scans, but I had to put this lecture last 2.5.
No, that's okay, that's fine.
I'm sorry, I concede that. I'm sorry about that. I'm with you all the way. So you can see all the air. So this is really a neglect. Patients failed to see dentists for a long time, and because of anxiety, and she's finally taken the courage to come in. Okay. Now she expects to lose all the teeth. Okay. So we're not just going to look at her from the dentistry point of view, but we need to look at her from her biopsychosocial point of view too. So you need to really make these patients feel comfortable. So that, you know, it's a privilege to treat those patients because they trust you. And you have to explain them this rationale of science, the rationale in their own format so they can understand that you will be treating them. So my advice in this case was like, look, we're going to try this. We got a number of deep cleaning to be done. As she requested sedation, but once this is done, we'll allow to see how your response is. But you have to do a lot of home regimen. We'll talk about that, and then we'll reassess. Okay, and then if I'm not getting a response, as a consent letter, we'll discuss with my specialist. So you need to see him. So that's really. Because if I refer, I felt that should probably disappear. We said we'll treat you here, and then we'll refer you to Stan and send a response for this patient. But having said that, there's a lot of bone loss, but actually there's some mobility of the bridge work here. And when you mentioned a few other things, we'll come to it in a minute. Let's look at treatment sequencing. Okay, we're talking about sequencing, right? We're planning, stabilizing, then we reassess. Then we diagnose it first to see if our treatment is working. And then we worry about anything else we have to do restoratively. And there's a maintenance. And we talked about maintenance. It starts not from the end, but from the beginning. I want you to think of it all the time. So the patients are coming to see you. The maintenance protocol starts at the first visit. The patient cannot maintain cannot commit to the practice or to a group of colleagues that you feel comfortable that can be able to be looked after. Then you have to really seriously think about the patient because they should understand and own their problem. It is critical that they own the problem. So let's look at this patient overall point of view. I'm going to show you the pictures here. Okay, here's the initial image for the patient. Anybody like to comment? What do you see? Is a patient on class 2 DF2 posterior upper bite? No, that was the one point. I mean, do you see? We can see, like, to me, I'm not really. I mean, that's a process of knowledge. I'm never worried about the crowding. It doesn't bother me. It just doesn't bother me. All I want to look at is the foundation. I mean, the prognosis of the teeth and support future reconstructions. But how do I know? How do I know these teeth will be okay to treat the patient for the future? I mean, patient, for you to say, look, I'm not sure if you're going to save those teeth, but we can do our best to hang on to them as we can. How do you feel the patient will feel when they think that they're going to have all their teeth out in the first place? So there's a lot of psychology here, but you're basing that on your clinical findings. There's a lot of plaque, there's a lot of calculi, there's good impaction. So if you do all that, maybe there's a really good chance that we can improve the inflammation and help our patient. Stan, could you comment on this?
At least now we can see where we are. Now, if you're looking at, was this before, how much cleaning have you done? Because I'd expect a lot more deposits on the lingual of those lower anteriors.
No, there's an initial presentation.
This is how, so she hasn't had any scales, nothing at all. Is that correct?
Yes.
Okay. All right. Now you went through, you've got your probing depths, you've got your radiographic. I would like some periapicals as well to show me bone levels around the low anteriors, which are not clearly shown on the OPG. And then, no, that's fine. Now, what I will say is that's the initial presentation. Go back to your charting. Right. So if we start from the upper right-hand side, go around each of the individual teeth, right? You've got your mobilities, you've got your probing depths of loss of attachment there, and classify, what's the prognosis of that particular tooth? Are you going to hang on to that tooth? Are you going to remove it? At what stage will you remove it? You try and retain teeth as long as you can, but if it's totally hopeless, like a 7, what benefit will there be in retaining it that 7?
Yeah.
And I will.
Well, benefits remove the 7's removed.
Okay. Is that the only tooth you've extracted?
Yes. Absolutely.
That's the only one there, low anteriors. Okay. So then the next thing is, obviously there's deposits. You go through oral hygiene regime. You're going to start cleaning that patient up. You're going to try and remove, because there are deposits, we will be seeing a relatively good response in this particular case.
Absolutely. And based on that, I was able to give the patient some reassurance that I anticipate good response. And because of this, you know, when we talk about chief concern, if I can just proceed, you know, bleeding on, the article is bleeding on brushing, and pain has come, redness on the gums. I mean, she saw this redness, she was very concerned. That's what made her really come to the dentist as well. And when you talk about mobility, patient says my teeth are mobile, is drifting. That really concerns them because there's a lot of factors involved in mobility. Okay, so to me, that's very important. And mobility, as you know, could be caused by a number of factors. And food impassion is another issue where when teeth are mobile, you got a major inflammation, you got food impaction, then that's a really good scenario for infrabony pocket formation, because food goes in between the teeth and the periodontal bone loss will go very, very quickly for this patient. When you talk about chewing discomfort, then you're looking at the occlusion and you look for the usual parameters. So all this comes into play for me during that time. And like Stan, you would also say that part of the periodontal treatment will be to refine occlusion, to reduce and redistribute loading, okay, to allow periodontal membrane healing. Would that be correct?
Yes. Yep. The main thing, as I said, is to reduce that inflammation, right? How do you do? Plaque control, removing super and subgingival deposits, you will see quite a reasonable response to that. And then that's the next stage you get. So the first thing is you've extracted the hopeless prognosis on the 1-7, everything else you will retain for the time being. You'll also advise the patient there are other teeth with questionable to poor prognosis, but initially we will hang on to them and see what the gingival response can produce.
Good. The other problem was when the patient was talking about herself, because she was very, very shy, very anxious. We made her relax when she was talking, is that Dennis mentioned to her, oh, we can really make your teeth beautiful, that we can fix it up and do all this work, all that. And that's what intrigued me the most, because aesthetics is the last thing at this stage for this patient. She's in discomfort. Okay, we need to sort this out first. Now, will aesthetics become a problem in the future? Concern, yes, it will, because as the patient gains confidence in your treatment, they can see the result, they feel better. That's another scenario, maybe 12 months down the track, and she has decided to have that done. But let's just go back. You know, there was a talk about occlusal trauma, which is an important part of this treatment. And Dennis need to understand what occlusal trauma is. That, I mean, is there an occlusal trauma because the teeth are drifting? There's a good chance there is. But does the trauma cause gum loss? No, that doesn't. There's no evidence behind it. We all know this. Okay, but if you have a presence of plaque and subgingival calculus, there's absolute chance of that causing further bone loss. So you need to adjust. Besides doing scaling and root planing, you have to really get the occlusion refined so the patient's really, really comfortable. And would you agree with that, Stan?
Yeah, yeah.
And also the
main thing is controlling the inflammatory response rather than the occlusion, right?
Yes, but the occlusion is a part of it. It's an overall treatment to reduce the inflammation, because if teeth are moving, then you're not allowing the inflammation to settle at the same time. That's an overall package. So little fermenters, little contact spaces drifting, you know, just helps the patient's comfort and able to sort of chew function in a normal way. And again, there's no evidence real that it causes inflammation of the ligament occlusion. So occlusion has got little part of it. Main thing is to get in their side and get those plaque out and clean them. So what we did for this patient is after scaling and root planing, and after we go from here to there. So that's the first 4 weeks post-op. As you can see that we reduce inflammation. Still some redness here that tells you that there's probably some more happening in there. So we have to go a bit more deeper. But what really made me happy, Stan, here is that there's a good response so far after 4 weeks. Would you agree?
Yes.
And I'm looking at lingually. You can see that there's the lingual gingival height is pretty high. So there's a dip in the proximal col area that lingual gingival was pretty high. And I'm really, really happy about this because that something will happen later on will help me to help the regeneration process. So she's responding to treatment very, very well in this particular scenario. I'm looking at different angles of this patient and reassess naturally. And this is before and that's after, different angles. And we can see that she's getting good response, and will take time for this tissue to heal. And saying, well, let's help you reassess. And then looking at in 4 weeks, the same case scenario, and we're having a good response with patients. So would you like to comment on this, Stan, in terms of?
So this is 4 weeks. Where do you go from there? So you've gone around, have you done it quadrant by quadrant, or how did you do the debridement?
This is on the IV, so the whole mouth in one go. Okay, it's an IV and IV. And then we're going to go back in as there's a resolution. My therapist will go back in and do, cleaning and doing some slight local, under local individual deeper cleaning if it's required, as we assess the response or the healing response. Obviously, there's some areas here that's still redness, so there must be some calculi present in those areas as well. I can see some calculi. I mean, basically, looking at the original images, you can see there's amount of resolution, but giving time for the gums to heal, then you're in a better position to access some deeper calculi. Would that be?
So that's 4 weeks, is it? From photo 1 to photo 2?
Yes.
Okay. So you've gone back, you've debrided again?
Yes.
For any areas. How long would you leave it?
Well, with the brightest areas, we left it for a good 3 months. We reassessed it. Her hygiene was impeccable. She's really changed. There's no more pain. The occlusal fremitus was refined, but it kept, as the gum was healing, and fremitus reappeared. We readjusted, and basically we went back from here, looking at 12 months post-op. Basically, it's the upper arch, and this is the post-op 12 months. There seems some gum recession here. There's reduction in swelling here. Still some redness there, so that needs to be looked at a bit more on the upper arch. And this is the before presentation of the upper arch, and coming back 4 months post-op. This is the after presentation of the same mouth after upper arch. So still some inflammation still present here, and that's been taken care of. So she comes every 4 months, and I think so far, given what she has, she is able to, improve oral hygiene. And when we look at, you probably want to know the measurements here, obviously.
Yes.
And we have to bring the patient back for you, Stan, so we can remeasure it. Because Christy couldn't find the measurements in the other software, so we will measure this. And there's a marked reduction in.
So what's the difference in time? When was the second recharting?
The second charting, very similar. Well, second charting was about 9 months later, okay?
You haven't done any charting in between after your initial debridement?
Debridement, there was a charting 3 months, and I didn't put that in here. This is at 12 months. This is exactly.
So what was it like after 3 months?
It reduced about 70%. And after 12 months with regular brushing, it really improved. There was a regeneration that occurred during that time. And there must be bleeding here, which wasn't charted. I just don't believe there's no bleeding here. But nevertheless, the attachment levels have improved. And the patient was so happy that she would come in and I was looking after today. But that tells us how much improvement it's occurred over the 12th time with good, home care and supportive therapy, as well as doing good initial diagnosis and assessment. And
one of her complaints, sorry, Sarkis, was mobility. Would you like to comment on that? What was the mobility like on the lower anteriors?
Well, lower anteriors, as you can see here, okay, it's so. I'm sorry, where's the lower anteriors? That's the upper. I need to go to the lowest. So in other words, let me just go back. Okay, this is before, this is the upper. Okay, I'll go lower. 1 second. This is the lowest. Okay, so you get the lower anterior mobility is improved significantly by 1. It is not 0, but it's really improved significantly. Okay, so from our end, as far as I'm concerned, that was also helped, not just the periodontal healing mechanism, but also the fact that there was a femdus present that was adjusted, refined. So we would spend at least about 3 hours on that during that period, if I say, to be able to refine and create contact distribution patterns. So it's like there's no contact on the inclines of the teeth, so teeth don't shift, and it makes a huge difference. I mean, that occlusal refinement, patients really feel the comfort when teeth doesn't move as they close into the intercostal position, and that was really, really important, I believe, for this patient. Looking at the upper arch, you can see that there's marked improvement in mobility as well. Well, there wasn't that much mobile here, but nevertheless, there's improvement in attachment levels. So still, we're going to work on the molars, which are always difficult to clean, and she understands that. But nevertheless, we really feel that a good result has been achieved for this patient. Now, one of the reasons that I find that we have to be very, very diligent in our diagnosis initially, before we treatment plan, is that imagine if one had to reconstruct this patient doing multiple implants or crown bridge work. What a catastrophe would that have been from the patient's point of view, and also for the dentist, because somehow your whole restorations are useless because teeth are in the foundation is just not there and teeth are falling apart. And that's something that we need to think about when we talk about good dental treatment. So just looking at the lower arch here, that was initial presentation. This is at 4 weeks, and I like the fact that dips slightly, because I know there'll be some sort of regeneration here. And we didn't do any regenerative procedure. All we did was a simple scaling and root planning. That's all we did. And you can see the gum response here, how we have improved, especially between those two. Look, there's a gum papilla reformation, given half the chance. For this patient also took on a healthy diet, lost a lot of weight. She felt good about herself. And how we really change and look at the interproximal papillary formation. I don't think that any other form would have given this. Given them, all I'm trying to say is given them half a chance, how it really improves the integrity of the gum tissues and supporting bone. There's a good response here, obviously, from the periodontal point of view. I mean, you can see that there's been some adjustments of, during the, you can see I've done some enameloplasty here of the upper teeth to reduce the mobility of the lower teeth and of the lower teeth enameloplasty. But having given those two lingual gingiva, there's a good regeneration of tissue and formation of papilla. We almost have complete, formation of the interproximal papilla with the removal of any of the dark spaces. So fill up the contact area. And this is a good biological response and not a mechanical response. And be able to save this patient's teeth rather than subjecting the patient to unnecessary, implant or full mouth clearance procedure that is not required. I mean, we've got a lot of studies then that you can manage these patients for life, even having a good periodontal therapy. What's your comment so far?
Have you extracted anything in the lower left?
No.
It's just the way the photo is. There's nothing right at the back, is it?
No.
You've got your two premolars.
Yeah, it's all there. It's all there. As a matter of fact, I can show you that's before. I can show you this after.
That's good. You've done well with your debridement. I'm just checking your x-rays.
Not me. My hygienist, Christy, she's number one. I'm sorry to tell you. Okay, she's number one. I mean, in terms of helping me in-house. And she's your regular referrer, Stan, because I think you and my hygienist talk to each other quite regularly about this. But all I want to say is that given half the chance, we can get fantastic response. And we can maintain this, okay? And but to say, I mean, can someone in the audience please comment on what would you do from here? In other words, we're doing risk assessment here at this stage. What would you do? Do you tell the patient, well, you come every 3 to 4 months, now we can say every 6 months, or we can say every 12 months. What would you do for this patient? Can someone say, make a comment? No comments, huh?
None so far, Dr. Sarkis.
None so
Well, if
far?
no, I'll comment.
Yeah.
Go ahead.
Yeah,
Nimesh?
yeah.
Hi, Nimesh.
Hi, Stan. Now, every 3 months, of course, monitor the patients and ask for patients' needs. What do they want? Of course, sorry to join you halfway, but I think I would want to go into a bit of a cosmetic if she wants to do level those teeth and maybe look after those teeth as long as possible, because I think there is nothing to lose here by keeping this dentition as long as possible.
Okay. All right.
Would you, I mean, I would want to do a crown on that black looking tooth if the root canal and everything is going good there.
Here, you mean on the low 3-4?
If that's a concern for her.
All right. Any other comments? Fair enough. Any other comments?
Why is there a crown on 3-5? When did that happen?
3-5 crown. That's not crown. That's 3-6. That's 3-6.
That's 3-6. It doesn't look like it.
It looks like a crown there. No, it looks like a crown.
Yeah, but that looks like it's on the 5, not because the 4's the grey one.
Is a 5.
And then there's a
5 is in. 5 is actually lingually. Okay, position. That's why.
It's an instanding tooth if you look at it, Christine.
Oh,
it's
okay.
instanding. The 5 is instanding. You can just see part of the buckle.
Inside the arch.
Okay.
All right. Look, I'll take all your answers, but there's something else I'm thinking for this patient. You see, that's the problem. I would never rush in the trip. I mean, patients will say to my front desk, I want a cosmetic improvement. I agree with you, Nimesh. I agree. Because now they're confident. Now they're ready because they feel good. And she's lost nearly about 20 kilos. And she looks really good. I mean, so I was amazed the change, how much periodontal treatment helps the overall general health, the cardiovascular system, a lot of other issues that go with it. You understand what I'm saying? But the important thing, something I need more from the audience. What is something that can happen at any time if you're not careful?
Relapse.
Relapse. What relapse of what?
Of the perio?
Yes. Why?
Well, it's hard to maintain all of those teeth when you neglected them for so long. You know, they're all keen in the beginning and then they get...
But she's happy. She's so, you know.
It's improved, but it could relapse.
Okay.
She might run out of money. You never know.
Okay.
I have a suggestion, comment. Could it possibly, because she's so confident, she thinks her gums are all stable, she might think, oh, then I don't need to come back.
Correct. So this is something that's important to explain to the patient because they feel confident that it's done, but this is our duty.
Maintenance for life.
That they need to understand. Okay. Now, Kath mentioned interesting comment that it's hard to maintain oral hygiene because of severe crowding and rotations, and I accept that. So, I mean, you could definitely think about doing some orthodontics here, like clear aligners. If inflammation is controlled and patients are able to do that, you can correct them and improve the arch line. That's one way of doing it. There's no question about that. but you have to be very careful. What would you do if you're doing orthodontics here? How would you do orthodontics? Dr. Howard, not you, the audience. How would you do orthodontics?
Could we please have an occlusal, the occlusal view?
Did you see it before? Huh? I showed you occlusal view here. There. 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 Here's your view. Here's your view. So we control the inflammation, improve the pocketing and mobility. Okay, if you were doing the orthodontics, to all the dentists who do orthodontics, or if there's orthodontics in a group, okay? So if you had to do orthodontics, what would you do something specifically that's very important in this case? Something very important, couple of things, but I'm quite familiar with orthodontics. What would you do? What would you do something to be really careful of when you're doing this?
Move the teeth very slowly
Why?
because you don't want to, well, resorption, and because you don't want to move them too quickly because you're going to have a relapse and the teeth are going to get mobile again.
That's a good question. So how would you do it slowly? I want something more before you slow, something before that. You need to do what?
Dr. Sarkis, Jesse Holt says, moving teeth out of the bony housing and recession.
Yes, but we know that, but I want before that. You give me something else about, I want to know, what would you do? I want you to start, this. I'm trying to make you think. Everyone wants to give me the answer. I know the answer. That's not the answer. I want you, what is the principle of what would you do? Okay, so you should tell me the following, and I'm going to have a dot line there, okay? One, you control inflammation. You maintain, a healthy state, okay? All right, now the patient really wants aesthetic improvement, says, can you move my teeth? And you say, I can. But what do you have to do? He said, I was mentioned before that, Len mentioned you move the teeth very slowly. To move the teeth slowly, what do you have to do? Employ what? What was you going to employ? What sort of wire would you use? Or what sort of force would you consider? Come on, you're going to talk.
Sorry, Dr. Sarkis. So it's you are talking about what wire do you use? So now we maintain the periodontal health, the pocket depth is stable, there's no bleeding, and we are doing ortho. So
Yes.
night eye 012, 014 will round wire will very gentle.
What's the meaning of 012? What's the meaning of 012? Tell me. I want that.
Passive self-ligation.
Catherine said. Catherine, why don't you speak, Catherine? You want to have live forces. That's what I want.
Yeah.
That's the answer I'm asking for. You have live forces. Okay. What's the second thing you're going to do in this case? Besides like what you have to control, something else that's really important. So I don't want you to think like carpenters. I want you to think biology. This is what's missing in the education. So what would you do? You've got life forces. What do you have to control now? What's the most orthodontics?
Proclination. We don't want any proclination.
Okay, but so what you have to control then?
The tipping of the teeth. We don't want any tipping.
What is needed for that? Don't worry about it. Anchorage. Wow. Who said that? Alexander. Right. You need life forces and anchorage. I'm a prosthodontist. As far as I'm concerned, everything's prosthodontics. Orthodontics is prosthodontics. You need life forces and anchorage. Am I making two things you need? Life forces and anchorage. Don't worry about the rest. Yes? I didn't hear that. Steve, what did you say? Okay. So Everyone says we don't want to keep those teeth outside the socket. If you had to do orthodontics, I want one X-ray that will tell me a risk factors. What would you do? So you don't want to tip those lower anteriors. I understand that, okay? Because first you're not going to tip, you want to intrude them. What would you do? What X-ray would you take to see where you are?
Lateral ceph.
Lateral calf. I want more than that. It's not enough for me. Sorry.
What? Okay.
What? Sorry.
Yeah. You on the CBCT that shows everything?
What would you see? What would you look at coming CT? Christian, be quiet. Calf, what would you look in coming CT? This is all diagnosis. Look, I've done more than 3,000 cases of orthodontics. I'm being honest with you. I understand a lot of things. So if you need orthodontics, what would you look for? That's straight up. What would you look? What am I looking? If I'm thinking of, if you get the orthodontics, what would you look at?
Lower one to MB.
How much?
Calf. Can you speak calf? I'm not going to answer it. You got to say it. Okay, right. Labial bone.
Labial bone.
Lower labial bone. Right. If you haven't got much of a labial bone, what are you going to do? If your lower labial bone is thin and she's on a thin biotype, the chances are you've got very little labial bone. See, I know all this. She's thin biotype. It's with very little labial bone. Okay, PAOO. Here's a question for you, and I accept that, PAOO. But what I'm trying to tell you, in this patient, I would be very careful doing orthodontics because not sure which way it's going to go. I will wait another year if I'm going to orthodontics. I will just make sure she's really compliant. Okay, that's very important to me. I need to do risk assessment because there's something about periodontal patients who have advanced periodontal disease. And what happens is this. Okay, I'm coming back. So I'm just going to come back to this. What happens is this. This is a standard textbook. I just took a copy of the textbook. Sorry, just coming back to that. Okay, what happens is this. See, patients, okay, that successful treatment, stable periodontitis patients remain at increased risk of recurrent progression of periodontitis. In patients who are not at risk, there's no real evidence of the increase of risk periodontitis unless the risk factors change, unless other things change their life. But nevertheless, is your patient periodontitis here, therapy stable, fine. Okay, cases some general information fine, but here there's unstable case. So in my mind, would you agree, Stan? Would you wait a little bit longer?
Yes, yes. We went, initially you were thinking of Invisalign. Why did you change to?
No, I'm not saying, I just have the audience. But Invisalign, you can't control the forces. That's another problem I have. Or you have to have a lot of aligners, okay? And that may affect the oral hygiene, maybe, I'm not sure. You can use a chlorhexidine gel inside to help it's not the issue. The issue is that in this case, what determines the case is the thickness of the lower labial cortical plate or the lingual cortical plate. I was hoping someone said lingual cortical plate because just as important, because if you're going to do slight tipping, the root's going to come up from a lingual end. But we're going to think of all those things. Okay, so that's something to consider. PAOO is all fine, I accept that. Okay, but this patient may not be the best candidate for orthodontics. Okay, and sometimes I would prefer to tell a patient, look, you know what, we can accept the situation or very light forces, provided she accepts the fact that we might lose some teeth in the process. So the patient has to take on the risks of possible loss of tooth as a result of orthodontic treatment in this case. And that should be well written in your consent letter. So your consent letter should reflect your rationale for treatment, possible complications, and your contingency planning while you're doing so. And they all understood that. And everything happens in my surgeon's room. So to understand that more carefully, as you can see, as we proceed in testing the system, it's all very well. It's all very well, but most important thing is we reassess each time, reassess. 12 months, we reassess. We have to reassess. If we don't reassess, your case may go haywire. If patient leaves, risk factors change. You don't know where the patients are. That's why your hygienist or therapist will be constant maintenance. They run a show that's very, very sort of a, you know, organized like a Swiss clockwork. And that's really important part to maintain those patients, because every time when you're doing it, you're recessing, you're recessing, you're recessing. That's what periodontal treatment is, because you're maintaining soft tissues. It's a dynamic process, it's biology. It's not carpentry. All on 4 is carpentry, nothing else. And that's going to fail. You're going to have more failures coming in. So while you're general practitioners, you're going to think, how do I maintain biology? Because when you take that bone out, you get a block of plastic because you think you're a bloody good carpenter, means absolutely nothing when things start failing. So unless we have maintained this patient and then we realize patient wants something more, I still wouldn't do it on 4 in this patient. I still wouldn't do it because I can maintain teeth. So to answer the question, we go back 12 months post-op. Okay, we maintain. You can see good cortication of bone. I know that's formation of the cortical areas. There's no rugged area. See over here, it's all rugged, the bone. Okay, now we've cleaned the mouth up. There's hardly any calculi there. I only commend my therapist, Christy. She is fabulous. I call her the plug fascist in the nicest way. She's the best. She just gets in there. I look at those teeth. I know only Christy can give that cleanliness. Just perfect job. It's excellent work, and I commend her for that. And I mean, look at the results here. Okay, we're maintaining. Even here, there's a bone formation coming in. So give it half a chance. And Stan, would you consider after 12 months to do a bit more regenerative therapy, maybe, if you want to proceed, or just leave it as it is? What would you think?
4s, I'm happy to accept 4s. It really now depends on your restorative treatment plan. What are you going to do there? If the patient is happy, obviously aesthetics with those anteriors, you have to do something about it. Then we can do. Now, there is obviously some vertical bone loss there.
Yeah.
4 millimeters, I'm happy to retain.
Okay, there's a bit of vertical loss here. I can see that.
Yep.
Yeah, maybe I should go back in and give a bit of a scrub. Okay. I've got a question here, and the message question is to you. All, now, Christina Howard, all the restorative dentists, the stage is yours. If you had to restore, what type of restorative design would you consider? Let's look at the upper arch. This is really putting the pressure on, isn't it? Here and here. So what sort of restorative design would you consider?
A hygienic design, allowing her to clean as easily as possible.
Okay, Alexander, that's good. And what that hygiene design would be, in your opinion? I'm not, if you just feel free. It's not a, you know, I just want to see what would you do in terms of hygiene design?
Equigingival margins, narrow pontics, making sure that the embrasures are easily cleansable.
Excellent, excellent. Okay, all right. I'm happy with that. Okay, what would be something very important to consider for this patient before you do a restorative design? Now I'm talking the other side. We've got to control, we've controlled the foundation. It's all looking schmick. And patients, you know, compliant. She maintains good oral hardship. He's probably going to look at the infrabony pockets on the canines laterally. It's all very well. Some will determine, bless you, Stan. Some will determine.
Thank you.
Someone needs to determine what else would you look at, because this is a tricky question, but it's not really a trick question. Okay, you talk about restorative design. Hygiene is excellent. The access to hygiene is excellent. And the patient's ability to be able to maintain hygiene is excellent. But now she really wants you to make a, come on, I want something more.
A diagnostic Mac box wax up.
Yes, but before that.
Before that.
She wants you to make her look beautiful, smiling, beautiful. So what would be the first thing, we talked about the design, but something you need to know before you know where you're going. We're almost done. Christina, Natasha, it's not a bedtime yet. Just give me a few more minutes. You're almost done. Nani? So your margin design. So I'm going to give you a hint. Where would you place your margins if you're doing a new bridge work, and why?
Supragingival.
Okay. Why?
So they can be cleaned easier.
Okay. But okay, that's good. But she wants to make it look beautiful. So what would you look at before you decide all the other factors?
That you get all the gingival margins lined up.
Okay, fair enough. But something else I want. Any takers? Alexander?
Dr. Sarkis, Catherine says black triangle.
Dissolved.
Gingival display on smiling would be a big factor.
Okay. Is Isadora here? No. Isadora here?
Yes, sir. Yes, sir.
Here?
Yes.
Okay, we've controlled the perio. We're going to create a hygienic design. Okay. Okay, we understand all the hygienic design. That's all good. But something very important that determines how I incorporate the margin, the position of the margin, the design, something that's really, really important that I need to look at.
Small line.
Smile line.
Bar, gingival bar type. Is that what we're looking at? Or
Smile line. Higher smile line will determine where you're going.
Do you have a photo of that, Sarkis, after the perio?
Perio treatment, smile line?
Yes.
No.
Is it a high lip? What's it like?
I didn't too. I purposely have removed it. The reason I have removed it is because too many clues. Okay.
Well, we need the clues.
yeah, you're making life harder.
No. They're gonna make it easy for you. Okay. You gotta think. All right. It's a, I mean, everyone knows I do all the cosmetic aesthetic work, but that's not the issue. I actually gotta make sure everything's right. So that's the last thing, as a matter of fact, in all my cases. Aesthetics is the last thing. Okay. Get everything else right before you get to aesthetics. But having said that, smile line. So you got a really high smile line. When she smiles now, gets the gums from here all the way there. So how would you fix the problem?
Botox.
Botox, yeah.
Botox. Well, fair enough. Okay. So can you see how complicated this gets now? So what else did you do? How would you fix the problem? Okay. Let me just mention a couple of and this is my take on this. Okay. I would do in this particular case. There's a gross gum asymmetry. All right, so you need to have some sort of symmetry. I would ask Stan, probably, depending how much bone we have, to see if we can improve the gum levels as much as we can, especially here. I will ask you to improve the biotype by thickening, doing connective tissue, or do a mucograft, or anything you could desire. I want to thicken these tissues all around here, so I can maybe get some OV8 context here, but in a way you can manage to clean. So I would then use my temporary bridge to guard the gingival gum margins. Okay. Am I making sense?
Yes.
Okay. And I have a temporary, so I can see and manage the cleansing of my temporary bridge. And I have a modified temporary bridge to make sure it's schmick, gums are under control. Give it in temporary, so a good 3 months, everything's spot on. Then I'll reconsider copying it and design the whole bridge to the final. Am I making sense? Okay. That's how you do prosthodontics. Okay. There's no shortcut. You got to do things in the right way. If you don't, I can't help it. So when we talk about dentistry, okay, you got to test the system. You need to test the system because you are knowing and doing risk management for your patients. So we talk about doing all the important parts here, okay? You need to be able to assess the biological response. You are not a carpenter, you're a doctor. You got to assess biology. Biology drives the equation, not carpentry. Okay? We understand that patient risk in periodontitis is always a risk for periodontitis. It's never going to go away. It might get worse. Keep reassessing your patients. This is what we did at the college. It's education, which we teach. Understand, okay, to plan for results and not for procedures. Because you have to plan for procedures, we are carpenters. If we plan for results and looking at biology, then we are doctors. Because it's all about biological response and not about carpentry. This is what we teach at the college. If you really want to know good dentistry, this is the college for you. We teach on how to think, how to diagnose. That's key to it. Any questions so far? Happy to teach, happy to answer.
Dr. Sarkis, somebody's written, I've seen your magic to eradicate black corridors, rebuild smile line and lasting aesthetics without Botox. No shortcut, all in ICODP.
Well, thank you, Catherine. You've seen this, darling. Thank you very much. I appreciate that. And the most important thing is that just remember there's no tricks, but there's good science and good experience in terms of learning how to mold and maintain biology. You know, I've worked with Stan for the last, 25, 30 years, Stan. And we have such a good long results in building tissues, building the site, improving the outcome. And you need to think, see, if you really, when you join the college, the first thing I'm going to teach you is how to slow down. I'm going to teach you how to slow down and not to try to rush in your treatment. You know, I don't want you to walk in your surgery with a revolver filled with zirconia crowns and inlays, onlays, and shoot them down one by one. Don't. Please sit back and think for a second. Is this the right treatment? That's why when you come in, you start mentoring on case-by-case basis. There's no recipe. That's what I'm trying to explain to you. There's zero recipe. Okay, you're going to plan for results, not procedures, because that's how it works. You got to think every case is different. Every case requires unique approach, unique assessment. There's a patient factors, you know, that includes their medicine, there's some biopsychosocial well-being, all the other things. And there's the lips and the gums and the bone level, tooth level, all these things, and the general health comes into play. And your treatment has to be based according to what your diagnosis and history taking is. So it is important. That's why Stan has never seen this case before. And he was thinking the same way as I was thinking, because here's a picture, but I'm not looking at the picture. I've got a lot of things brewing in my head, exactly what we're trying to do. This is what we do, we teach. We don't tell you, oh, you do this. No. That's fine. If you want, we'll teach you, but you're not going to be doctors. You're just going to be doers. You're going to be carpenters. If that's what you want, I'll run courses for you. But if you really want to learn dentistry, then this is a course for you. Having said that, any questions so far? No questions?
None, Dr. Sarkis, no, not as of now.
There was a question about porcelain veneer, so it's all here. Okay, it'll come up soon. Please, there's a new website coming up for the college. It's a beautiful website. Take a long time to develop. So I suggest have a look at that and think about it. And now, you know, regarding Botox, just quick, I never give Botox to the masochists. I disagree with that. It actually causes a muscular dystonia, which means they can't chew anymore properly. So be careful what you do. Don't subscribe to anyone who says you're going to do this. Okay, facial Botox and anti-wrinkle treatment, I can understand that. I'll do some of those. But generally, I avoid doing masochists, okay? There's other treatments available. And you learn that when you do the course, and there's a TMD. Where's the next one? So I don't like doing occlusion and TMD, but I just say it makes sense because occlusion and TMD are two different things, okay? But will rewire your brain, will rewire you, will put a lot of neuroplasticity in your head and will change you, will make you think, wow, now I know exactly what I'm doing. You'll be very confident in doing all this, all the cases from simple to complex. Remember one thing, as a specialist, I like to simplify complex cases and make it simple. I don't like complex cases, but I like to simplify the complex and make my life and the patient's life simple. And I wish you good night. Till in 2 weeks' time. Thank you all.
Thank you, Dr.
Thank you.
Sarkis.
Thank you.
Thank you, Dr. Sarkis.
Thank you.
Thank you, Sarkis. Thank you.
Thank you.
Thank you, Dr. Sarkis.
Thank you all. Thank you, Christina. Welcome back. You
Thank you,
sound.
Dr. Sarkis.
Thank you. Thank you all. Thank you. Thank you. Thank you very much for joining us. Thank you. I'm happy about that.
Yes. They're getting into it.
Yeah, very good.
A lot of these are repeats. They're coming back.
Yeah, they're intrigued. They want to learn. That's the main thing, and I think that's why we put the college together to be able to help the dentists in looking at things differently, rather than looking from a commercial point of view what the dental companies projecting in terms of what the dentist should do to such as the case of like if you mention put across the whole face, we talk about how to preserve teeth. Nobody wants to go because it's easier to take a tooth out for an implant, charge $5-6 grand, end of the story. We don't have to remember that, but you pick up all the periodontitis, we pick up the other side, and now we've got a problem. We don't have to fix the patient's mouth, we have to fix their head, and they're going to fix their mouth. It's complicated. So the course really, I think, is a good one. It'll go a long way. I'm getting good feedback. I'm getting good feedback now, and I'm quite happy about that. Well, thanks.
Okay, you're welcome. If I can have the links earlier on, then I can go straight in. Right?
Can you make sure that Stan gets the link ASAP, please? Oh, Shraddha, you
that day's fine. If I can, that way I can go in there.
Done.
Okay, Sarkis, all the best.
Thank you. See you there. Thank you. Bye-bye. Thank you.